Good afternoon and welcome to United TV. It is time for Bariatric Friday. Today is April 4th, 2025. We are going to discuss another important topic for bariatric surgeries for those who are dealing with morbid obesity. And for whatever the reason is, it can be from complications, it may be inadequate results, there may be some new health concerns. Revision surgery is a really important part of the bariatric surgery. So as much as we focus on overall bariatric surgery process, pre and post, revision is another important issue that we need to discuss for those who know that there are other alternatives after they have their first surgery. And this is, we are going to discuss this. It can be, again, for many different reasons, but not every treatment is going to give the same results, and not every procedure and every treatment plan is going to be the same for everyone. So that's why we are going to have the area of expertise, Dr. Isaias Irgau, here with me. Dr. Irgau, how are you doing?
I'm doing great, Kemal. It's great to be back on another session of Bariatric Friday.
Well, it's always good to have you. So we are going to talk about the revision surgery, and bariatric is one of those touchy topics. Morbid obesity, we try to educate the public, be a resource for our patients who are going through the process. Yet this is still, limited understanding is still there. And revision surgery itself, when we say revision, it's almost like, I had these term issues from the early on when we had the gastric sleeve. I'm like, why are we calling this gastric sleeve? So this is, and I really thought that you were making cutting the stomach, and then the extra pieces were being tied
Wrapped
and
around
then making
it,
the stomach smaller, but it wasn't that. It was actually really just cutting it.
Yeah.
So, and the revision is like, we are not revising anything. We are actually doing another procedure. And then there are multiple options out there. But let's start with, why do we need a revision if bariatric surgery is the solution? I can see people thinking, hey, I thought I was just going to be okay when I had the surgery. So if you can give us the background on the revisional surgery and why it's needed.
Absolutely. So as you correctly say, revisional surgery is a process whereby we go back and either tweak the first surgery in somehow, or we actually change it to a completely new procedure, right? So it's an intervention essentially on a pre-existing surgical procedure. Revision surgery as a whole, actually, as a term, is actually very common in surgery. You can have a breast reconstruction surgery that requires revision, either because the outcome was not the way the patient expected, or because there were complications that needed to be fixed. Or if we do surgery, for instance, to remove a tumor from the intestine, and we have cut out a portion of the intestine, and we have reconnected it, we may go back and do something different because there was a complication or another intervention was needed. So repeat surgery, revision surgery, is actually not unusual in surgery. So when we talk about revision surgery, we're essentially saying we are going back and undertaking an additional procedure or changing the procedure altogether. But the question that you raised at the beginning, which is really very important, is why do we need revision surgery in bariatric surgery if the bariatric surgery is the answer? Well, bariatric surgery is the answer. It's a treatment. It's a medically necessary treatment. And like all medical treatments, we don't always get 100% of the results that we expect. This is just not possible for any treatment in any field in
Not
medicine.
necessarily just for the surgical, but even with the medication, everyone is responding differently.
Absolutely, absolutely. So why is bariatric surgery treated any differently than any other medical intervention, right? If a patient goes to a doctor because they have cancer and the doctor removes that cancer, but then the cancer comes back, you don't say, oh, we've done one surgery and we cannot repeat it. Well, if the problem exists, if there are issues that need to be addressed, the doctor needs to address them appropriately. So to expect bariatric surgery to have this unattainable standard of 100% perfection is just another symptom of castigating bariatric surgery
Stigma.
into a stigma
Right.
from which it cannot get out. Right? That's what they're doing. And this is actually real, Kemal. There are insurance companies, health insurances, that say, for instance, you're allowed to have only one bariatric procedure per life. Where is that coming from? Why are they saying that you can have only one shot at a treatment of this complex disease? Right? It makes no sense. It just, they're doing it because they can, because there is such stigma against obesity that no one is defending the treatment for obesity appropriately.
So
right?
I don't want to take your attention to a different issue, but it's just like I couldn't help but just remember what happened yesterday. Because it all comes down to the understanding of the industry and in some cases people. So when we do bariatric surgeries, in some cases where we may have the hiatal hernia, and for the relative value unit, the standard term, this procedure is 50% more complex than gastric sleeve.
Yes.
So when you open the patient, and in some cases we may know that they have hiatal hernia, but in some cases we don't know this until we open the patient. Now, you are there, you're a surgeon, and then the understanding of this medical director on the other side was, so there isn't enough documentation of this. I'm like, what documentation do you need? So I'm there. I said I'm there because I was like, you trained me so well. So then I kind of confused him. He thought I was a surgeon. I said I'm there. So then the patient's open, and then I see this more complex problem. Not only the problem needs to be taken care of, but if I don't, it's going to impact the outcome of the main procedure.
Yes.
And I put all the documentations out there. I put everything properly. And you tell me, your coder tells me. And no disrespect to anyone, but there's a surgeon who's deciding to do what's right versus there's some coder who doesn't have the same education and tells me, you don't have the right documentation. Then I said, so you want us to close the patient and they schedule them for 3 months, 4 months, and then taking care of the hiatal hernia at that time. That's a crime.
Yeah.
I said, that's a medical ethic issue where my surgeons won't be able to do that because it's not the right thing to do. So this is important because this is the, unfortunately, issues that we deal with.
Yes.
And
Yes.
I was really upset. Now you can tell, normally I don't get hyper on these, at least in the show. So it just made me so mad.
Absolutely.
So I'm like,
Absolutely.
what do you want us to do,
Yeah,
right?
yeah.
So then I realized that he just doesn't know.
Yeah, and also because there is, there is this attitude of impunity when you attack bariatric surgery in any way, right? So they put patients, they put surgeons and caregivers on the defensive because they are taking care of obesity, right? A complex disease. So going back essentially to what we were saying earlier on is that a number of patients may require what we call revisional surgery, additional surgery, or repeat surgery, either because there have been some complications, right, some symptoms that have derived from a particular procedure, or because the patients have not achieve the weight loss that we want them or resolution of comorbidities that we want them with a particular procedure. The most common revisional surgery, as you know, is revising a gastric band to either the gastric sleeve or to the gastric bypass. Right? When you compare the gastric band with the sleeve or the bypass, is clearly a weaker procedure in terms of its outcome. There's no question about it. The appeal of the band was because it's a procedure that is perceived as being less invasive than the other procedures. So there was a time in which patients really had a lot of gastric band procedures undertaken. Some patients did well, but others struggled because there were complications related to the band, or struggled because the weight loss could not be sustained afterwards. And because obesity comes back or the comorbidities return, patients rightly are requesting a different approach, a different surgery that will help them a little bit more, with more impact, which means removing the gastric band and then going ahead and doing a gastric sleeve or a gastric bypass. So we are doing revisional surgery in such situation. Another revision surgery would be to go from the gastric sleeve to gastric bypass, for instance. This happens much more commonly if there are symptoms that occur, for instance, after the gastric sleeve. One of the symptoms that can happen, for instance, is heartburn. Not everybody gets heartburn after the gastric sleeve, but some patients can have heartburn, and in a minority of patients, that heartburn may be very difficult to control, even with medications. In which case, we recommend surgical treatment, and the surgical treatment would be changing the gastric sleeve into gastric bypass. Because of the way gastric bypass is constructed, the anatomy actually prevents acid from going to the food pipe, and therefore the heartburn or the reflux is resolved. So the thinking behind revisional surgery essentially is to help the patient, help them either because they're having symptoms that require intervention, right, to a different procedure, or because they are still struggling with weight loss. Now, there are a number of things that have to be considered before we recommend revisional surgery, of course. One is understanding that revisional surgery is a step up in terms of the potential risks of the surgery, because we're operating in a field that is no longer virgin, right? We have intervened there, we have created scar tissue, and scar tissue does not heal in the same way as natural tissue would do. So when we intervene, we understand that the risks of the surgery are higher. A higher level of expertise is needed to undertake revisional surgery because of the complexity of the surgery itself. And then the other thing to consider is what is the likelihood that the revisional surgery will be successful? That we have to consider as well, particularly if we're doing revision surgery because the patient has not achieved the weight loss that they expected, or because they didn't see the resolution of comorbidities that we all expected. We have to say to ourselves, did the procedure fail to achieve this? Or did the patient really did not comply with what we asked them at the beginning? Because as we always talk about, bariatric surgery is a tool. And a tool is as good as the person utilizing it. So we have to make sure that there are fundamental changes in lifestyle of the patient, right? Because you could end up in the same situation even after the revision surgery if those changes are not undertaken. So we don't take revision surgery lightly. It's not something that we do at the top of a hat. Obviously, we have to consider many issues, including, of course, the risks of the procedures themselves, the type of the procedure that would be appropriate, but also we have to consider how the patient handled themselves with the first procedure and what led to failure in the first place.
So the first lap band surgery, we were one of the first ones who did it in Delaware. When was that?
That was, I believe, in 2002. Dr. Wynn and I performed the first lap band surgery in the state of Delaware.
So 2002 is 23 years ago. Ethan, how old are you? Okay. So this procedure is younger than Ethan.
Yeah.
Right? Sorry, Ethan, I'm using you here, but since you are in your 20s, it's okay. So part that people maybe also are missing is it's so new. And in 2002, that's what was available to us.
Yes.
And then 23 years ago, like we talk about other treatment plans may fail, but they've been doing that for years and years and years. But the thing is, technology, medicine is improving
Yes.
and advancing. So then this is where now the band is not the only solution. So then we, in 2010, I believe we start doing gastric sleeve.
Yep.
And so this is still so new, but then one of the things, like, from the clinical standpoint, you may not say this, but I don't have a license, so I'm going to say it. So there are patients today, if they are in front of us, band and sleeve, I'm going to say, okay, sleeve is what we need to go with. But when we didn't have the option of sleeve 12 years before sleeve was available, of course, so many of the revisions are actually coming from those bands, as you were saying.
That's true. That's true.
So, but it's improving.
Yes.
So now when the failure of sleeve versus band are not same, but still it's possible.
Yes.
And then when one of the things that we do gastric bypass, and bypass is the last kind of step in the surgery scale for us, but there are some patients, they may need to get the gastric bypass from the get-go, even if they are younger, because if they have certain conditions, we won't be able to gastric sleeve. So some of those things were not available to us before, when now technology is more advanced and we know and we have enough cases, enough outcomes to see what's happening. So I think, when someone gets a hair transplant, I think I used this example with Dr. Wynn the other day for something else, they get that multiple times.
Mm-hmm.
So, and the reason is usually not because they lose the new ones, because they still keep losing.
Yep.
So now they have to add more to cover the new loss.
Yep.
Okay. So no one is saying, hey, why are you doing it again? Right.
Yeah.
So that's kind of like that issue will probably, by the time we do these for a couple more years, there will be enough people. Now, most importantly, we have auto dubbing now, so meaning that now we are available in 7 other languages.
Oh my
right?
God, that's amazing.
7 or 8. So you are pretty
amazing.
good in French. Dr. Gail Wynn is doing excellent in Portuguese, Italian, Hindi, German, Japanese, and there are a couple others. So now the more people are going to be educated with these, because we'll be able to reach out to more people.
Absolutely.
So
more countries.
now the going back to the issue, as you were saying, that there may be some risk. This is at a next stage or next level in terms of what we are discussing in terms of the risk, and those needs to be discussed with the surgeons, and also what failed us in the beginning. Is it the type of surgery failed us, or is it our approach failed us?
Yes.
So, this issue of compliance, because we do this every week, my mind works a little bit differently anymore. So everything that I do throughout the day, I try to see if there are any examples that may be relevant for what we are discussing. So last week, you remember my QuickBase database that I use for the weight, like the diet journey? I thought it was only 2 months ago when I stopped using it.
Yeah.
It was September when I stopped entering stuff. So I didn't think it was that long ago. But one of the things that I kept the same regime and same routine, so it was not anything different. But then I forgot how much, how quickly it's now, I'm not doing it anymore. So that means my compliance actually went down a little bit, because I know that I cheat a little bit more than I used to.
You don't document, that's right.
But then nothing is reminding me that. So this week I started again. Actually, it was last Thursday, I believe, I started entering. So the April entries are done. So, but then now I'm more careful, because I know that something is reminding me that. For October through December, 3 months, and then 3 months or 6 months, it was off the table. So I don't know how that happened.
Yeah.
So this is how easy to
Yes.
kind of fall out of the wagon. So it's just so easy.
Yes.
So, and I don't need to be on that every day, just entering everything, but I still do because it keeps track of everything that I do, and then it reminds me of what I need to do. So patient needs to realize what failed at the first time, and they need to be honest with themselves. If they're having difficulties, they can come to the show, and then I can talk to them about being honest, because it's important, right? So if you don't know where the problem is coming from,
Yeah, no, that's true.
how are we going to actually address the main issues? So now, in terms of improving quality of life with the revision surgeries, what do we expect after the revision surgery?
Actually, that's important, particularly because it pertains so much to the most common revision we do, which is removing the gastric band and going to the different procedure like the sleeve or the bypass. One of the potential downsides of the gastric band is quality of life can be impacted, because depending on how tight the band is, patients can find themselves really not knowing when the food will actually go down when they're eating or not. To the extent that very often they will be out eating with friends at the restaurant, then suddenly they have to go to the bathroom because they cannot keep the food down. So that back and forth between inability to tolerate, the food, or the band being loose so that they're not really losing the weight, gets into the quality of life a lot. So that is not seen so much. In fact, that is really rarely seen with the gastric sleeve or the gastric bypass. So there is really improvement in quality of life just from that perspective when we go from band to sleeve, and patients will tell you that. But then, of course, if the failure was also related to the fact that they have not been able to get rid of their diabetes, of their high blood pressure, or their sleep apnea, when we do a much more impactful procedure than the sleeve or the gastric bypass, there will be resolution of these problems, and that will have an impact in their quality of life as well. But another point that I would like to touch upon, Kemal, is this. We have to look at bariatric surgery very much in the same way we look at any other treatment in medicine. Right? So if a particular treatment was not successful for a particular individual, and that happens a lot, then we have to look for alternatives. Right? Patients should not lock themselves in isolation thinking, oh, this is not working because of me, because it takes them back to that stigmatization that they have suffered through because they have not been able to do it by themselves, right? We don't want them to think that way. If they are struggling, either because the weight is coming back or if they have not lost enough weight, they need to come back to us, to their home base, to their bariatric practice, for us to be able to look at things with them. Yes, of course, revision surgery should not be the first option, but revision surgery should not be taken off the table either as an option, right? We have to look at everything in its totality. So in fact, the first thing I will do when patients come back and tell me, hey, I'm struggling with weight regain despite my band being tight, I look at the situation and I try to understand what it is that they're eating. Is the band maybe too tight and forcing them to eat softer foods that may have too much calories, right? And not controlling their hunger well. Maybe releasing the band a little bit will help that situation. Do we need to do an X-ray to see whether there is malposition of the band after so many years that needs to be addressed? Or has the patient encountered a crisis in their life that made them lose focus, a divorce, loss of a job, other things that happen in life to all of us, and all of these things have an impact on how we live and how our health is. So that totality of the approach is important. That's why we send them to nutrition. That's why we do blood work. That's why we do imaging first to try to address where the problem is. And then we present them with different options. And the options are from the less invasive options to the more invasive options without taking anything off the table, off the options, right? Because we want to make sure we help our patients. Ultimately, they have nowhere to go but to their bariatric practice for us to be able to help them. And in this, it is important that, first of all, patients understand that it's not necessarily just their fault that things are not working out, right? and that they need our support. And also we have to convince society as a whole also that bariatric surgery should not be treated any differently than any other treatment when it comes to repeating the surgery or addressing the issues with different interventionists if the first intervention did not give the outcomes we expected.
Well, it's not magic, it's a tool.
Yes.
And that's what we have to remember.
Yeah.
So I think the issue of like someone seeing the results from the first surgery, things don't happen. You mentioned something about like the weight regain or not losing enough weight, but there are also patients in this who did lose enough weight, but then there's a condition called reflux.
Mm-hmm.
And in those cases, we may need to do another surgery. This is not just, revision surgery is not just for the weight regain or not losing enough weight, but also taking care of other issues that maybe patient may be dealing with. So again, the worst thing that they can do is do nothing.
Absolutely.
And knowing that so much available, and then the decision that we have to make. But again, I want to kind of keep this away from the failure, because this is not just about the failure. Because if you look at 30 years ago, certain treatments are how it's being done versus what's happening today. It's not the same.
Mm-hmm.
So you remember my mom had this bypass surgery, and the cut that she had on her leg,
Mm-hmm.
if she had the surgery here, it didn't have to be that big. Now, she had a successful surgery.
Yes.
Her recovery is good,
Yeah.
but that cut, that's all the way from
harvest
down
the
to
vein.
the ankle.
Yep.
And when I was talking to one of our cardiologists, I showed him the picture, and he said, we wouldn't do this.
Right.
I mean, the outcome may not change, but
Yeah.
the techniques would be different.
Different.
So, therefore, we need to look for solutions, not
Yes.
for what obstacles we can find to stop
Right,
the process.
Absolutely.
So, and this is why we are here on a regular basis. So, many people they see results after the revision surgery. The important thing that you mentioned, keeping in touch with us,
Yes.
keeping in touch with our nutritionists. We have 5 full-time nutritionists on site, full-time in our office,
Yep.
available for our patients. So it's not just for pre-surgery, but also for post-surgery. So, and I think that's what we have about revision. So this will be, again, available in 7, 8 different languages. So now I have to kind of be a little bit more specific. It's so weird, like when you see yourself speaking in French, all of a sudden you are so like good. I'm like, can I do that?
And the translation is actually very accurate.
It
I mean,
is.
you showed me the Italian version
Right.
earlier on, and it was
Well,
spot
the one
on.
that I sent you with Dr. Wynn,
Yeah.
like it
spot
looks
on.
so real.
Yeah.
Right.
Yeah.
So, again, that's the advancement the technology has.
Yeah.
Same thing in medicine.
course.
So it's kind of like
Of course.
related to what we are doing. So, Dr. Irgau, thank you so much for joining us.
Thank you for having me, Kemal. I appreciate it.
We'll be back next week with another topic. We have 2 patients that we are trying to get in touch with. We want to bring them in and discuss their experience with the surgery. And
Terrific.
that's going to be interesting. What we did a couple of weeks ago was really, we got a lot of good responses for that. So we'll keep doing that. And if there are any other patients who may be willing to share their experience with us, please reach out to us. And we'll be back next week. Thank you so much.
Thank you.